Hello, everyone. I'm Dr. Gregory Nikogosyan. I'm an assistant professor of psychiatry at University of New Mexico School of Medicine. I'm particularly within the Department of Psychiatry under the Division of Behavioral Health Consultation and Integration. It's a pleasure and honor to be here for the Armenian American Medical Society 24th Annual Conference. And today's topic, we're going to be talking about essentially psychopharmacology and pregnancy um, to maybe help the primary care clinicians or any other clinicians who are concerned or don't quite know what to discuss with their patients when they're asking, is it safe to continue certain medications? Is there things they should be worried about? What's the risk to their baby? These can be a lot of difficult questions, particularly in an area without a psychiatric consult. And so let's proceed. For disclosures, I do CME writing for American Physician Institute. Other financial things include Substance Abuse Mental Health Services Agency, SAMHSA, grant funding for opiate relief, for research. And then I'm a full owner of More Mine and LLC. I'm also not compensated, but I'm a board member of Alzheimer's Care Armenia, which is now under actually the Armenian American Medical Society. So that's amazing news. But I want to just disclose that as well. So learning objectives today, the big thing is with discussion about psychopharmacology and maybe prenatal or during pregnancy, it's always what I like to say is a risk discussion. There's a risk of not taking medications and there's a risk of taking them, and you have to kind of balance, those two things. And so some of the things I wanted to explore is during pregnancy and for lactation or breastfeeding, various medications. These include antidepressants, anxiolytics, stimulants or non-stimulants for disorders such as ADHD or ADD, medication-assisted treatments for opiate use disorders. That's a very big topic in pregnancy. Mood stabilizers, which are used for many things, but primarily something you would think about would be like bipolar. And then antipsychotics, which can be used for bipolar disorder, augmentation for depression, or schizophrenia. And so these are kind of topics I hope to explore and make you all more comfortable in having these discussions with your patients. So starting with the focus on depression in pregnancy, the first thing I want to look at is what is the risks with untreated depression in pregnancy outside of any medication management. There's not a lot of data. Research is continuing to always come up with case series, case reports, some prospective studies. But we do know that there's a possible risk, not a lot of good data for a possible miscarriage. We do know that there's growth effects with untreated depression in pregnancy, increased risk of delivering with low birth weight, typically 2,500 grams or less. Or less than 10% for age-adjusted weight for the infants. There's a higher risk for preterm delivery. And again, these are all associations. It's not causal. If you're depressed, you're going to have preterm delivery, but for some reason, these things are kind of associated. And so this includes preterm deliveries, which is less than 37 weeks of gestation. The good news is there's no studies linking congenital anomalies to antidepressants. There was one where there was some thought it would cause some type of congenital deformities or abnormalities, but that was with larger data sets shown to be not true. And what's interesting is the newborns of depressed women have similar physiological profiles as their depressed moms. They've done studies looking at cortisol levels, the dopamine and serotonin levels. They've done electroencephalograms looking at brain activity and vagal tone for sympathetic or parasympathetic responses. And interestingly enough, they found that these things are abnormal in the newborns as well as the mother. And for instance, like the EEG or the electroencephalogram, they found that there is asymmetrical activation of the frontal lobes, both in the mom and in the infant. And for instance, with the vagal tone that we're used to hearing for many other medical reasons, they found a low vagal tone in the newborn and in the mothers. So it's very interesting that these physiological things go across the placenta. How mom is feeling and thinking probably affects how the baby's feeling and thinking, and it's kind of important to kind of help balance these things. And so what about long-term effects on, kids? There's a lot of mixed studies. Some have mentioned, is there possible developmental delay at 18 months with untreated depression in pregnancy compared to children who were born to mothers who were not depressed? Again, it's with a lot of these studies, because these are not like double-blind control studies, there's a lot of possible confounding factors. But it is important to know that it seems like depression has some influence on the baby's development. And so what about anxiety? We know based on what limited data we do have that preterm birth is at a higher rate. Spontaneous preterm birth is at a higher rate as well. You can see the odds ratios of 1.5 to 1.4. Again, low birth weight as an adverse outcome if the mom is overly anxious or has an anxiety disorder or meets criteria for a disorder. There seems to be more hypertensive disorders in pregnancy. Unclear if the anxiety is driving this or if there's other physiological and medical causes that are increasing blood pressure that also can have an increase in anxiety. So it's kind of, is there a medical disorder that's also fueling some of that anxiety state? Um, if there's anxiety in pregnancy for the mom, it's a predictor of postnatal depression as well for the infant. And there's been some associations again with developmental delay, lower academic achievement for the child. They're born with greater emotional reactivity, overly sensitive to their environmental stimuli, and possible more behavioral problems as well through adolescence. Um, and fMRI studies and other kind of volumetric studies of the brain have shown high maternal anxiety is also related with lower brain volumes in the prefrontal area, which is important for our executive thinking, but also in many other areas of the brain. So what about antidepressants? Because we use antidepressants to treat depressive disorders and anxiety disorders. The big class is the selective serotonin reuptake inhibitors. And as you can see, most of those are like fluoxetine, sertraline, citalopram, escitalopram. Um, the one that had some historical history of possible congenital anomalies was paroxetine, but that's shown to be pretty much disproven as more data came in. They found that it was fine if this medication was continued during pregnancy. What I will say is most people don't use paroxetine or fluvoxamine, but if a patient is coming to you and they're already on these medications, it's working for them, they tell you they're worried if they come off that their mood's going to worsen, the general thing most reproductive psychiatrists would do is continue the medications. The other classes is serotonin norepinephrine reuptake inhibitors, such as duloxetine, venlafaxine, desvenlafaxine. Then there's the older medications, the tricyclic antidepressants. The most common ones used typically, if at all, in pregnancy would be the nortriptyline and disopramine. And then we have a lot of atypical agents. They're kind of newer medications that have kind of more novel mechanisms of action. And many of you have probably prescribed these already, but just to go over them, mirtazapine is one of them, which is a noradrenergic and a specific serotonergic antidepressant. Then we have bupropion. It's a norepinephrine dopamine reuptake inhibitor. The one thing I'll say is for some reason, I see a lot of clinicians start bupropion on people with high anxiety, and this can make things worse for them. And so I just want to caution, if you're going to treat anxiety and that's the main thing that's kind of affecting your patient, I would hold off on the bupropion and consider one of the other agents. Then we have trazodone. It's not really used for depression anymore, but you may see this a lot in patients for sleep, is what it's commonly used for. It's also a serotonin antagonist reuptake inhibitor. Then there's these newer agents, vilazodone and bortezomib. These are kind of like partial agonists for the serotonin receptor, reuptake inhibitor. And then it's complicated because they act on multiple serotonin receptors, and some of them is more agonist or antagonist properties. But again, they work really well, but it's just things to consider when managing patients. Now, something that's really interesting for postpartum depression, they have these new neuroactive steroids. Essentially, they're made from progesterone, and there's two medications out there, brexanolone and zuranolone. The brexanolone is an IV formulation only, and then they have oral formulation for the zuranolone. There's really no data at all, and the FDA has not commented at all in using this in pregnancy. So my recommendation would be to at this time to just avoid using these agents unless you've had consultation with a psychiatrist. But in postpartum depression, it is treatment to consider. And so what are the risks? Starting with that first class, the one you guys are probably most familiar with is the SSRIs. Um, Before going into the side effects, I think the ones that are the safest to probably use is like Lexapro or escitalopram, sertraline. Those don't have a lot of med-med interactions with the cytochrome P450 system. And people generally tend to do pretty well on them. And then you can add citalopram on that too, which is Celexa. The issues with fluvoxamine and fluoxetine, they can have a lot of drug-drug interactions, and they're pretty potent inhibitors of the cytochrome P450 system. And so I tend to just avoid that in anyone that's in the medical setting or on a lot of medications. And I tend to go for one of these other agents like sertraline, escitalopram, and citalopram. Now, for selective serotonin reuptake inhibitors, these wonderful paper by actually a colleague of mine here at University of New Mexico, they kind of did this chart of like untreated depression versus SSRI, and it kind of gives you that risk analysis that we're talking about. And so, what about congenital malformations? For untreated depression, the risk is unknown. But what I can say, if depression's untreated, are they not doing the prenatal care they need to? Are they not taking, the vitamins? Are they engaged in behaviors that could be harmful to the child or to the infant? And so, could that pose them at a higher risk of doing things that can cause congenital malformations? Um, and then as far as we know with the SSRIs, it has not shown to increase risk at all for any malformations. How about neurodevelopmental outcomes? After the child is born, is he going to have delays in speech, walking, various things, milestones that they have to meet through development? So untreated depression, there's increased risk of negative impact on intellectual and behavioral functioning in childhood. There's research showing increased risk of mental health disorders in the offspring. Um, and then for the medication side, when underlying maternal mental illness is controlled for, they don't show any evidence of an increased risk of lower IQ, autism, behavioral consequences because the mom was using an SSRI while pregnant with the child. And so this is something that's very important to just highlight that I think there's a lot of fear in pregnancy to be on any medications because you want to be protective of the child, but in not treating the mental illness, you may actually be setting them up for actually more risk. What about complications at delivery? For untreated depression, as we talked about before, risk of miscarriage, preterm labor, low birth weight, preeclampsia. There's increased rates of C-section instead of vaginal delivery. And then, of course, in the postpartum, worsening mental health symptoms, and then the mother may have difficulty bonding with the child, which is very important for that healthy development and ability for the child to learn how to relate to people and those complicated dynamics. It starts with the mother's bonding. What about medications? So at delivery, that's where there's some risk. So there's this neonatal adaptation syndrome. It could be up to 30%. Essentially, this is essentially where the baby has been getting this serotonin from the mom because they've been on these medications, and now the serotonin's gone, and they tend to have what seems like what someone have if they quickly stop their antidepressants, which should be kind of like flu-like symptoms. The other thing is this persistent pulmonary hypertension of the newborn. It's a controversial risk. And if it exists, it's at a very low absolute risk. But it is something I would discuss. And then there's this possible risk in people that are set up to possibly have an increased risk of bleeding, like they're already on anticoagulation or blood thinners. of postpartum hemorrhage. We do know that SSRIs, anything that blocks that serotonin reuptake, also has an effect on how platelets aggregate or how they kind of form like the clots and it prevent the bleeding or stop the bleeding. Again, this is typically not a large issue unless someone has multiple medical comorbidities. A lot of people in the hospital with a lot of medical issues are still on antidepressants. It's only when they have like active GI bleeding where we like stop the antidepressants. So I'm not as worried about that. But it is a thing to discuss with the patient. And with this neonatal adaptation syndrome, kind of going back to that, there used to be this thought of like, well, how about we stop the antidepressant right before delivery, taper it off, and have the child maybe not go through this. But the recommendations, at least from all the big reproductive psychiatry centers, the big one being, and it's a good resource, would be the Mass General Women's Health program. It's not recommended. They've even recommended maybe considering to lower dose, and you'll see some psychiatrists do that where they may kind of decrease the dose by a little bit to minimize that risk of the neonatal adaptation syndrome. But again, the most important thing is you don't want to decompensate or worsen the mother's depression or anxiety. Um, Next. So the next class was the serotonin norepinephrine reuptake inhibitors. Very similar risks compared to the SSRIs. Um, because this has that norepinephrine component, the one thing I will highlight is at delivery, there might be a risk of this gestational hypertension. For individuals on these medications in the clinic, we typically look closely at the vitals to make sure they're not going into really high blood pressures because that norepinephrine component of this antidepressant can elevate blood pressures in any of us. And so that is something to look at. And of course, as we discussed, the risks with untreated depression remain the same on the slide. And then the next is more of these like atypical or newer agents that don't quite fit in those like classic categories. So mirtazapine is one of them. Um, there's less studies on mirtazapine, but the data that is available, whether it's case reports, data banks that people have submitted to, all of these things don't show any increased risk of congenital malformations. And what about developmental outcomes? There's no really good studies talking about the developmental outcomes, but um, you know, for the most part, it seems like throughout the antidepressants, there has not been any increased risk of poor developmental outcomes. And then, of course, complications at delivery. This neonatal adaptation syndrome can still be present. And so that's something to just consider. Bupropion. Here's another medication. Again, this one was the norepinephrine and dopamine. It affects those levels in the brain. Less studies than all the other ones that we've talked about. There's been some mention of possible cardiovascular defects, but these were like small studies, very small absolute risk, and unclear if it's truly causal or if it was confounded with other factors. But one idea might be because it is more stimulating. Is it running the heart at a higher rate? I don't know, but it's something to consider that there is a bit more risk with the congenital malformations here, although small absolute risk and unclear if it's truly because of the medication. Again, nothing was found for developmental outcomes, and there's some theoretical risk of less neonatal adaptation syndrome. Again, this is norepinephrine and dopamine that it's affecting. It doesn't have that serotonin component like the other agents that we were talking about. So, that's why that theoretical decreased risk is mentioned for this medication. And this is the kind of classic, really old antidepressants. As you know, the tricyclics can be very dangerous in overdose. It can affect, if you overdose on this, you can have sudden death, it can stop the heart, in certain states where they have medical aid and dying, part of the cocktail, they'll have a tricyclic in there at very high doses. And so I just want to let you know that there are risks when you prescribe tricyclics, particularly if it's someone with a high suicide risk. And so if there is someone that has had multiple suicide attempts, and they have done things impulsively before prescribing this, if you're feeling this is the only thing that's going to work for them, I'd highly recommend speaking to a psychiatrist or having them consult with a psychiatrist first, because that's a risk profile that you don't want to be burdened with, and have the psychiatrist kind of help mediate that. But as far as we know, there's no evidence of congenital malformations with tricyclic antidepressants. Um, Less studies than the SRIs in terms of safety. No evidence of poor developmental outcomes. And then because it does still affect the serotonin, it can have that neonatal adaptation syndrome. And so that's something to consider as well. What about breastfeeding? Um, just as a rule of thumb, all medications go into the breast milk. The question is how much of that gets passed on to the infant. Most of the antidepressants are less than 10%, and they're compatible with breastfeeding. And so, will there be some level of antidepressant that the baby's going to have? Yes, but based on the evidence, that level is not considered significant, whether it's from the FDA's point of view or by reproductive psychiatrists. Um, and so most of the data for antidepressants for breastfeeding are based off of medications such as sertraline, fluoxetine, paroxetine, tricyclics. Again, if someone's really worried about breastfeeding, my go-to medication is sertraline. I think it's a good medication, and relatively safe within the SSRI class that we have. Um, and then I like to avoid the tricyclics in breastfeeding as well, because again, they have strong anticholinergic properties. And so you want to look for in pregnancy, the mom's having constipation, urinary retention, but also no, even slight increases of anticholinergic agents within the baby can have significant effects in their physiological systems as well. So I tend to avoid this if I can, um, or discuss perhaps if they want to use any alternatives for breastfeeding if they're worried about this risk. And then, bupropion is largely safe in breastfeeding as well, but there have been two case reports of increased seizures. Bupropion in general decreases your seizure threshold. Really, the only people that are at risk are someone with a seizure disorder, someone that's had a head injury, um, any other physiological changes in the brain that's made them susceptible, or other medications that lower seizure threshold, substance use if someone's using stimulants like amphetamine, things like that. All of that can alter the seizure thresholds. But it is anecdotal evidence. It's not strong evidence to not prescribe this medication because of fear that the baby may have a seizure, but it's something to discuss about. So how about anxiolytics? Antidepressants are used to treat anxiety long term, but in the short term, if they're having severe panic attacks, they're not functioning, you may have to use medications to calm things down in, that initial month or two until the antidepressants are starting to help. As far as we know, there's no evidence with benzodiazepines for malformations in children. And or the Z drugs or the non-benzodiazepine hypnotics like zolpidem and all those agents for sleep. There is an increased risk for spontaneous abortion, especially in early pregnancy exposure, for both short and long-acting benzodiazepines. It is associated with high rates of C-section, lower birth weight, and then what they found is it seems like mothers who are using benzodiazepines or DZ drugs, for some reason, there's a high rate of newborns needing ventilatory support. In utero, we know that benzodiazepines have been associated with the NICU admissions or the neonatal ICU, intensive care unit, with an odds ratio of 2. And they've noted some long-term behavioral issues as well in the child, such as increased anxiousness, emotional reactivity, aggression, somatic complaints, meaning a lot of vague kind of descriptions of physical issues that they're experiencing. Abrupt stop of benzodiazepines can be very dangerous for mothers as well. It can lead to changes in their cardiovascular hemodynamics. It can lead to seizures, lead to miscarriage, preterm labor. I think the general rule of thumb is if there's abuse of any substance, whether it's alcohol, opiates, benzodiazepines, you want to do everything possible to avoid any like acute withdrawal state. And I think that's a rule of thumb because the consequences to the baby and the mom are significant in those withdrawal states. And so let's say the mom has been on the benzodiazepine. There's been that discussion of the risks. You want to look for in the neonate signs of irritability, sleep disruption, restlessness. It's hard to kind of gauge depression, but if they're really withdrawn and not really engaged with the mom, tremors, seizures. There's this thing called floppy infant syndrome, where low muscle tone, low temperature, they're in respiratory distress, they have difficulty suckling when they're breastfeeding. And then if we go ahead and talk about lactation, what we do know is the recommendation is to resume breastfeeding while taking benzodiazepines. Um, is there some risk of oversedation in the child? Yes, there's 1.6% of adverse symptoms in a study that had 124 infants. Again, it's a risk-versus discussion. Perhaps the mom would rather do other means of nutrition for the child than breastfeeding. And that risk, the other thing was in that study, it seems like they had other central nervous system depressants as medications for the mom, in addition to the benzodiazepines for some of the cohort. And so that's just something to keep in mind. How about other anxiolytics that are not controlled substances? The classic one is hydroxyzine that we probably use a lot for as-needed anxiety. There's not a lot of data. Current expert findings is that it's okay to use, but there has been mixed evidence of possible birth defects with antihistamines in general, especially in early pregnancy. And they found some link with the use of antihistamines in the Michigan Medicaid birth defect study for like cleft palates and things along that line. Um, if I had to choose, I'd probably be more hesitant to use hydroxyzine, given we do have other agents that we can do. Propanol, seems pretty safe for anxieties if the pressures will tolerate, not associated with any congenital cardiac anomalies or other major malformations. Gabapentin, also another one that could be used, not really associated with major malformations, but there is some adverse outcomes of preterm labor, small for gestational age, and possible NICU admissions. But from the studies, there seemed to be a lot of confounders in there. And what was interesting was there was a lot of what seemed like untreated depression and anxiety, which would have already kind of set up for at least at preterm labor and small for gestational age. The neonatal ICU admission rate kind of makes sense. Again, gabapentin is not quite like a benzodiazepine, but it still acts on that GABA receptor in the brain. And so it still has that like hypnotic effect in some ways. And so whenever someone's already taking, benzodiazepines or other sedating meds at night, if you pair gabapentin with that, you're putting them at an increased risk for, respiratory suppression and various things like that. And so kind of switching gears here to more substance. What about adverse outcomes for untreated opiate dependence or abuse? So for many societies, whether on the obstetric and gynecology side or the psychiatric societies, they recommend against any supervised withdrawal or detox for opiates. There's significant risk to the infant, the fetus, and the mother. And the benefits of treatment are greater than the risks of detoxing. And so what do we do know? Or sorry, what do we know about untreated opiate use? There's a 4.6-fold increase of maternal death during hospitalization, and that's pretty scary. A lot of these seem to be the cardiac arrest with adjusted odds ratio of 3.6, intrauterine growth restriction, preterm labor again, illegal hydramnios, stillbirth, increased C-sections. And they found that 1.5% of all deliveries are accompanied by maternal death for those with opiate abuse or dependence. One thing that I worry is if someone's kind of doing this medical detox, the mother's in such a state, and what I've typically seen is they'll leave AMA, return back to the hospital, leave AMA, return back to the hospital, and in between those, they may go use various substances, whether fentanyl, heroin, or whatever their choice is, and they're posing the risk of, you know, um, you know, a severe overdose leading to death. And I think that's probably what may be driving some of these numbers is leaving someone in this relative withdrawal state where they're distressed in their choices to go use, or sometimes the family members or significant others or friends will bring the substances into the hospital for them to use. I can tell you many stories of such incidences where, we found that, various drugs were brought into the hospital. And so what about treatment? Are the treatments safe? So the risk of malformations is lower with buprenorphine than methadone. Buprenorphine is a partial agonist. It's relatively safe. You can dose it up really high, and it doesn't have a dose-related suppression of like the respiratory system or the central nervous system. So it's relatively safe. And because it binds so tightly to those opiate receptors, you would need much higher levels of other opiate levels to override it to get pain relief, but also to if someone's seeking that high or euphoria from abuse of the medications. Methadone is a full agonist. It acts just like the other opiates, but it has other interesting properties. And it's a difficult medication to titrate sometimes because it has such a long half-life. You want to be very careful in how you slowly increase it because it can build very quickly and lead to a state where you're iatrogenically pushing someone into a very sedated and dangerous state. And so what do we know? A lot of medications in pregnancy need to be adjusted. Methadone is one of them. Sometimes splitting the dose is helpful in pregnancy, particularly in the third trimester. We know that doses typically have to be increased in the third trimester. What we do know also is, again, these are medications that have some sedating effects. So compared to buprenorphine, methadone has longer hospitalizations for the infant, the neonate, and also the mother, because there needs to be more observation of the child, make sure they're okay, because some of this does get into your system. So they found that 69% of infants compared to 52% for methadone versus buprenorphine in longer hospitalizations. And then 30 to 80% of women on opiate agonists like methadone or buprenorphine may report some issues with their GI system, some autonomic changes, irritability, high-pitched cry, poor sleep, or uncoordinated suckling for the child. And then there's this neonatal opiate withdrawal syndrome, which is what we were talking about here. Methadone can occur anytime in the first 2 weeks of life. Again, remember, it's a longer half-life, so that irritability, that high-pitched cry, that withdrawal state can occur. You may not see till a week or a week and a half, and it typically occurs 72 hours after birth in most cases. What about malformations? We know that out of 1,000 pregnancies, 60 of them have some malformations. Again, it's hard to say because it's such a high risk population in terms of various environmental exposures and maybe lifestyle behaviors. There could be a lot of confounding factors here. And especially if someone needs to go on methadone, they probably are not tolerating buprenorphine, and it might be because of a higher level of opiate use. So we just have to be very cautious. Also, it transfers to breast milk, but in the infant's plasma, it's very minimal. So the recommendation is to continue breastfeeding if they're on methadone. What about buprenorphine products? Again, this is a partial agonist. It's much safer. Shorter hospitalization days and shorter days for that neonatal opiate withdrawal syndrome compared to methadone. And because a high half-life is not as long as methadone, symptoms typically develop in that first 1 to 2 days, and then it peaks around 3 to 4 days, and it can last up to a week, whereas methadone lasted up to 2 weeks. It accumulates in the placenta, but it seems like the enzymes reduce the amount that actually gets to the fetus. This has slightly lower malformations compared to methadone, 50.9 instead of the 60 out of 1,000 pregnancies. And compared to methadone, 18% lower risk of all malformations, 37% being cardiac, 37% less cardiac, 45% less clubfoot, and 46% less oral cleft. And so this is also safe in breastfeeding, and the infant plasma levels are considered negligible or not significant. And then there's this controversy about naloxone or naltrexone. that is a component that's added to so Suboxone has buprenorphine and naloxone in there, and or naltrexone, sorry, and that's an agent that is a opioid receptor antagonist. And the reason why it's put together is to discourage intravenous injection of the buprenorphine products. And the reason why there's caution around using naltrexone or naloxone in pregnancy, because you didn't want to induce an acute withdrawal state in someone who's pregnant. But what the studies have shown is even in using the oral products that have this combination of buprenorphine and naloxone, that it didn't really lead to any increased adverse outcomes. But it is something to discuss. I generally, if someone's open to buprenorphine, and they don't want that naloxone or naltrexone, then they're fine. The worst that's going to do is the buprenorphine is going to latch onto these opiate receptors and prevent other drug use. So I kind of see it as still a safer avenue, even if they do decide to use it intravenously. Kind of shifting gears here. What about stimulants or treating ADHD in pregnancy? We know that women with ADHD who are taking off stimulants in pregnancy experience increased depressive symptoms, increased conflicts with family systems. They have a greater difficulty of having fun as a family, which is very important. Parenting becomes more difficult. They can get discouraged very quickly, especially in that new motherhood role. They're increasingly isolated from family. So you can see how it kind of can set you up in a bad kind of trend. So we're kind of in between slides, and this is our code word for this kind of virtual recording, and the code word is ketamine. And while I keep it on this slide, I just wanted to give an homage, to the late George Aghajanyan. He's a pioneer psychiatrist in neuropsychopharmacology. He's like one of the legends. He's really defined modern psychiatric neuroscience. Before him and his colleagues, a lot of psychiatry, yes, there was medications, but they never really looked at it from that more neuropsychiatric or neuroscience mechanistic viewpoint. And he's done some major feats, and one of the big ones was his studies on ketamine and how it led to regrowth and all these complicated processes that ketamine treatment for depression led to with the neuron synapses. And what's interesting is he wrote the paper for ketamine. He was studying ketamine and psychedelics for a long time, in addition to all the other antipsychotic or psychiatric meds. But ketamine particularly, he published it, I believe he was like 71, and it became his biggest published paper. And so he was like one of these guys where the whole department at Yale would talk about him as, very high energy and hungry till the last day. He was working well through his 80s and passed away at the age of 91. But I just kind of wanted to reference him here. So we're talking about ADD and ADHD treatments, so that risk discussion. So let's start with stimulants. This is like your Ritalin, you have your methylphenidate-based drugs, your amphetamine-based drugs. And so it is associated with a higher risk of neonatal ICU admissions and increased neonatal morbidity because of the central nervous system related disorders, which, for example, seizures. But again, there's confounders, unclear what you can associate clearly to the stimulants alone. So you just have to have that discussion. There's this association, but we can't say it's coming from the medication. There's not much data for lactation. They recommend using the lowest dose necessary to allow the person to be functional. It is in small amounts in the breast milk. They recommend doing immediate release over sustained release, as this may allow the mother and infant schedule to work around it a bit better. So you have methylphenidate-based drugs, a higher risk of miscarriage, child is born with lower APGAR scores. Large study did not find increased risk of major congenital malformations, but this is kind of older, and then some newer studies came out with some increased risk of cardiac malformations, particularly ventricular septal defects. Again, unclear if there's confounders there. And they described it as like a borderline statistically significant relative risk, and the absolute risk is 1.63%. So take it for what you will. Then you have amphetamine-based, less data than the methylphenidate, but there have been reports of birth defects in low birth weight, preterm birth, smaller head circumference, and problems in the newborn for feeding, breathing, fatigue, that lethargy. What about non-stimulants? There's a lot of medications we use for ADD, ADHD that are not these controlled substances. One of them is actually kind of an antidepressant, atomoxetine. It's a selective neuroepinephrine-only reuptake inhibitor. Similar side effects to the SSRIs that we discussed, or risks. No major congenital malformations or cardiac or limb malformations. Bupropion is used. Guanfacine is another one. Not a lot of data for those two. Then we have clonidine. It's a non-selective alpha-2 receptor agonist. This one be careful in because the blood pressure effects for the fetus and the mother could be problematic, so avoid. If I was going to use an alpha-2 receptor agonist, I'd probably go with guanfacine, much safer action. It's more selective to the receptor, less blood pressure effects. Then we have modafinil or modafinil, not recommended for use in pregnancy. Again, these are inhibitors of dopamine and norepinephrine transporters in the brain. And the reason why it's not recommended because there's good evidence that shows there's significant malformations and if exposed in the first trimester, up to 13% compared to the general public, where it's like 34%. Whether it's heart defects, hypospadias, torticollis, all these issues. So avoid if possible. Adverse outcomes, how about with bipolar in pregnancy? So we know preterm birth is higher, small gestational age, gestational diabetes risk. There's a high risk of instrumental birth, C-section, and a need for induction of labor, higher preeclampsia, placenta previa, hemorrhage, infant death is higher. And they found that non-adherence or discontinuation of the mood stabilizer results in significant risk to the fetus and the mother. If you were to stop the bipolar medications for your patient, whether it's lithium, an antipsychotic, lamotrigine, their risk of decompensating is anywhere from 37 to 85%. And what we do know is when that stopped, their suicide rates are really high, from 5 to 14%. And the risk of postpartum psychosis is also high with an infanticide, these psychotic thoughts to kill the child or to anywhere from 1 to 4.5% of cases. We'll talk about it a little bit. If you're going to stop any medication, the big one that everyone probably already knows is valproic acid, and to carefully cross titrate that. Anytime you're managing bipolar schizophrenia in pregnancy, I would definitely recommend having psychiatric consultation as part of that process, because that's a very tricky area, and there might be serious considerations of if the person will need hospitalization, if the medications are too dangerous to cross taper and they have to have that risk discussion, or they're already decompensated, meds are not controlling them, and they need like neuromodulation therapies like electroconvulsive therapy, which would be really the gold standard. And in fact, a lot of reproductive psychiatrists say if I go into postpartum psychosis or if I become manic in pregnancy, just go straight to ECT or electroconvulsive therapy. But, so what about treatments for bipolar? The big ones that you've probably heard about: lithium, valproic acid, carbamazepine, lamotrigine, and then antipsychotics are used for bipolar as well. So lithium in pregnancy, classically from med school and on, we've heard of, Epstein's anomaly, these cardiac malformations that expose in the first trimester. We know that you can get these tricuspid valve dysplasias. It's also associated with Wolff-Parkinson-White syndrome from more of an electrophysiology standpoint in cardiology. The old studies showed a really high rate of these cardiac malformations for lithium-exposed infants, up to 8%, and that's high. But we do know is those studies, have some problematic methodologies, and newer studies have shown that the rate is 2.41%, when in the general public for non-exposed infants, malformations are about 1.15%. So the risk is still there, but the absolute risk is much smaller. And most of the time, patients are already kind of going into their first trimester on lithium. They hadn't had the chance to have the prenatal discussion. And if someone's on lithium, you want to be cautious of stopping it because it is one of our better agents for bipolar. And the worry is if you stop the lithium, it may be hard to control a manic or hypomanic episode or depressive episode with other agents, because lithium is a very unique drug. It works really well for bipolar depression. And so if anyone's kind of coming close to this lithium discussion, please get a psychiatrist on as part of the team in that discussion. It's a bigger discussion. And, the recommendation, if women are on it and, they say this is the only thing that's helped them, even though the cardiac risk is there, a lot of reproductive psychiatrists will talk about the risk, but say, they'd recommend continuing the lithium, even though there's this cardiac risk that can occur. Again, the big things are because the physiology of the mother changes in pregnancy, there's this concern about the drug levels needing to be adjusted. So in pregnancy, you can have anywhere from a quarter to almost 40% decrease in lithium plasma levels. So a psychiatrist hopefully is following closely and titrating it appropriately by checking the blood levels. There's risk of toxicity. Lithium has a narrow therapeutic range. So if the mother becomes ill for various reasons and becomes dehydrated, or she's getting a lot of intravenous fluids, now her lithium level is almost nothing. There's all these fluctuations that can be problematic in pregnancy. For the fetus and neonates toxicity, you can get floppy baby syndrome as well. This low muscle tone, cyanotic. They can have issues with their thyroids, hypothyroidism in infants. They can develop this nephrogenic diabetes insipidus. And then what about lactation? What we do know is the levels of lithium in infants were not at a significant amount in mothers. There was no really adverse events documented with lithium use in breastfeeding. There was some transient changes in lab seen for the thyroid, for the BUN and creatinine. The recommendation is if the mother's on lithium and she's breastfeeding to closely monitor the child for signs of any toxicity. Despite this, no significant amount of adverse events. So that'd be looking at the TSH, the BUN, the creatinine every 6 to 8 weeks. And the recommendation would be use the lowest effective dose if possible. Valproic acid or valproic depakote is another name in pregnancy. Avoid. There's significant congenital malformation risk, over 10% absolute risk. Neural tube defects with first trimester exposure. And these defects can be cardiac, orofacial, skeletal, limb malformations. They have this fetal valproic syndrome of mental and intrauterine growth retardation is the word they use. There's an increased risk of autism and dyspraxia with an odds ratio of 17. There's a lot of mention of, if you're on these psychiatric meds, you're at high risk of your child having autism. And as you can see, that was not the case for everything we've discussed. But if there's one medication that we can say, you know what, you're right, you can have autism in your child, you have an increased risk of autism in your child if you use this drug, it's going to be Depakote. So just keep that in mind. There's significant cognitive and language delays in children born with this. And so this is a medication you should discuss birth control with any of your patients if they're already on Depakote. Or if there's a discussion to start it, there needs to be a discussion about birth control and what their plans for pregnancy are. And that's just the standard of care. What about lactation? After they've given birth, it appears to be safe. If the mom needs to get back on Depakote because that's what worked for her, that's fine. Carbamazepine in pregnancy, again, this is another medication, maybe less risky than Depakote, but it also is associated with like birth weight changes, head circumference reductions, increased malformations, particularly oral facial clefts, neural tube defects. So if they are on this medication, they usually recommend high folic acid, high doses of folic acid. There's a higher prevalence of behavior regulation in kids, anywhere from 12 to 14%. And then another agent kind of similar to carbamazepine is oxcarbamazepine, but there really isn't a lot of data. Again, just supplement with high dose folic acid if they're on it. And both of these appear to be safe in breastfeeding as well. What about lamotrigine? Lamotrigine levels also can fluctuate in pregnancy. They can decrease as much as 50% as the estrogen gradually rises in pregnancy. No increased risk of malformations, no neurodevelopmental outcomes, no risk of autism as seen in Depakote. Appears to be safe in lactation as well. There's been some case reports of this high sodium dehydration or cyanotic episodes needing resuscitation, but it was just a few case reports. And the classic thing with lamotrigine is the Stevens-Johnson syndrome, that skin kind of sequelae you can get in anyone. And so if a mother is breastfeeding or and is using lamotrigine, the big thing for the infant is monitoring and making sure they're not developing any new rashes, although none have been found. And then finally, we're kind of coming to the end here, schizophrenia in pregnancy. And so it's a very high risk profile. There's a lot of confounding with patients with schizophrenia because a lot of these individuals have really bad psychosocial support and are really exposed to a lot of different things. They're less likely to go to their OB appointments. They're less likely to take any supplementation, less likely to get regular nutrition. They have increased rates of unplanned or unwanted pregnancy. Bipolar also has a lot of increased rate of unplanned or unwanted pregnancies, particularly if they're in the mixed episode or manic episode. They have increased rates of tobacco, substance, alcohol use. And so all these things can already load the mother and the fetus for significant problems. And so what we do know is there's a high rate of discontinuation of antipsychotics in early or late pregnancy in these patients. Um, and just to give you a sense of how complicated managing pregnancy uh, as a clinician in individuals with schizophrenia, 41% of women with schizophrenia may require psychiatric admission during pregnancy. And there's significant difficulties bonding and attaching to the child. You can argue there's a lot of reasons why that is, but again, in schizophrenia, these individuals tend to have a harder time mentalizing or empathizing the viewpoints of others. So you can imagine they just may not understand the baby's needs. So what about antipsychotics in pregnancy? No neurodevelopmental long-term outcomes were found in children. You have the classic typical antipsychotics, which is mostly just the dopamine blockade, and the most data is for haloperidol. No significant malformations found. And then no significant malformations found for newer generation, what they call atypical or second generation antipsychotics. And some of them that were like looked at included olanzapine, quetiapine, lorazepam, aripiprazole. I didn't include this, but the other ones are risperidone that was included. Um, and so the databases are built, and again, it's a national registry database, and I think MGH is also following this. They're slowly gathering more and more data, but as they're publishing their articles on these databases, they're showing that they seem to be pretty safe. For the atypical or the second generation antipsychotics, particularly, there's a high risk of gestational diabetes and metabolic syndrome. The big agents that I would think about is olanzapine, clozapine, and quetiapine. Um, and then what we do know is, what medication gets through the placenta. It seems like quetiapine is the lowest at 23%, and then you can see it quickly climbs up to 72% with olanzapine. Um, and the other thing with the second generation antipsychotics, in utero usage, exposure, sorry, has been associated with spontaneous abortion, low and high birth weights, preterm births. Again, we just want to be cognizant that there's so many confounders for individuals treated on antipsychotics with schizophrenia and pregnancy. So there is an FDA warning for EPS, extrapyramidal side effects, where you get like the jerking, the rigidity, kind of the spontaneous movement of the arms, and a neonatal adaptation syndrome. Um, but the studies haven't really done a good job delineating is this really from the medications or effects of other maternal illnesses. And then for lactation, most of the data is for haloperidol and olanzapine, and it seems to be at very low or undetectable levels in the serum of breastfed infants. And no adverse events were reported for the other agents, such as aripiprazole, quetiapine, and risperidone. Before I go, risperidone is interesting because it can cause hyperprolactinemia. So if someone's trying to get pregnant, let's say you're doing prenatal kind of pregnancy planning, maybe don't use that agent. It may make it harder to conceive. The other thing that's interesting, if someone that definitely wants to breastfeed, aripiprazole is a partial agonist. There's three other partial agonists, brexpiprazole, and two other ones. But essentially, the partial agonist, when you're partially blocking that dopamine receptor, it can have the other effect where it may be difficult to produce milk. And so breastfeeding may become much more problematic on these partial agonists. So consider avoiding the partial agonist antipsychotics in postpartum if they want to breastfeed. So in summary, antidepressants are relatively safe when considering the worsening outcomes with the treatment of depression and anxiety. It seems like stimulants have a small absolute risk of adverse birth effects and can consider non-stimulant ADHD medications. Opiate detox is not recommended, and you want to use methadone and buprenorphine to make sure they're able to stick through with the pregnancy and do the things that you as a clinician would hope they would do. Mood stabilizers has to be carefully managed. A lot of them have a narrow therapeutic range. There's teratogenic effects with some of them. And then untreated bipolar definitely has high morbidity and mortality. And so those are things to consider. And then it seems like as we're getting more and more data from the databases, that there's increased reassurance of safety for use of antipsychotics in pregnancy, but to keep an eye out for more of the metabolic side effects for those second generation agents. And here are my references. And thank you, everyone.